Marker. Good morning. It is January 24th, 2023. We're getting ready to do our first surgery out of 6 surgeries today at Duke Spine Institute. We have 5 Duke laser disc repair surgeries for herniated discs in the lower back, and we have 1 Duke plasma rhizotomy for facet pain. Folks, this first patient is a perfect example of why we don't do fusion. He had a fusion done at L3-4 years ago, and now he has what's called adjacent means next to, segment, that means the disc above and below, disease. Adjacent segment disease for the spine means when you fuse bones together, then the disc below the fusion and above the fusion is susceptible to degeneration and problems. So we're going to now do laser surgery because he had a fusion done elsewhere. He has blown out the discs above and below the fusion, and you're going to see the screws and rods on the x-ray pictures in just a moment. We're going to target the disc below and above, and he's got stenosis or narrowing on the left side and right side. So he's got leg weakness, numbness on both sides because the nerves are being pinched by the herniated discs on both sides and the spinal stenosis, which is narrowing. All right, so we're going to get started. First step is to access the bad discs through the foramen. This is a minimally invasive surgery. It's done endoscopically. So you're about to watch a minimally invasive state-of-the-art surgery, endoscopic. I may be too low here. Yeah, way too low. So I'm going to go a little bit higher. How's blood pressure? All right, that's a little too high. I'd like to go a little lower. Yeah. Was he on thinners? Num-num? Well, he was on something. There's some antiplatelet activity for sure. Unless, yeah, that's fine. Yeah, well, it's fine, right? It's not too high. Blood pressure. Yeah. There you go. So the first step is to get into the bad disc using a needle. And the needle is a spinal needle, and I'm a little bit lower than 4-5 here, but I need to be a little bit lower, not a lot lower. Probably right here would be perfect. Let's see how that is. Shot. The reason I need to be lower is there's a herniation at 4-5 that goes up towards the head. So if I approach it from the bottom a little lower, then I can angle the scope up and get it. Second reason is there's bone graft up there. You guys see the screws and rods?
Yes, we do.
John? Well, those screws and rods have bone graft lateral, and it makes it impossible to get to the disc if you go too high. So I need to approach it from a lower position. Shot? That looks fantastic. Give me an AP needle. So we are at one disc, the L4-5. We're going to approach the upper disc with a separate incision because it's so far away. AP, that looks perfect. You guys see the screws and rods?
Yes, we do.
All right. Again, I didn't do that fusion. I personally think that fusion is not a very good fusion. Look at how much higher I have to start for the next disc. A lot higher. All right, so there's one disc we've accessed at 4-5, and now we're getting ready to access the 2-3. Shot. Any questions from our audience? Shot.
No current questions, but we do have a comment from SPX 730 on YouTube.
All right, SPX, nice. Welcome. Shot.
And they said the patient's getting some acupuncture along the way for free.
right? Yeah, acupuncture, exactly. Though acupuncture needles are smaller. Um, yep, that's why we broadcast, so you could see everything. By the way, why don't other surgeons broadcast their surgeries? The answer is they have complications, and they don't want you to see them. So surgeons don't broadcast their surgeries live. I'm the only one crazy enough to do it. Why? The real reason is because we don't have complications, and we want you to see that. We want you to see how much better AP this surgery is than other surgeries. And the competition that does fusions, open back surgery, they'll never show you their surgeries live because they're going to get nerve damage, spinal fluid leak. They're going to show you just how destructive open spine surgery is. They don't want to show you that. They'll scare everybody away. But we believe because we have no complications with this procedure, because it's so minimally invasive, and because it's so interesting to watch that people want to see it, they want to know the truth. We want you to know the truth. Sean? All right, we're accessing now the disc above, and like I said, normally we would do one incision, but look at the distance here. It's just too far apart. There's nothing I can do about that. Shot? All right, I'm trying to get around this facet, and I keep bumping up against it. Shot? Shot? All right. Shot?
We have a question.
Sure.
This comes from Canes25 on YouTube.
Hello, Canes25. AP?
And they ask, why do those screws look so far outside the vertebral body? Looks like the screws are barely in the bone. Definitely not one of yours.
Yeah, you're right. So on the lateral view, you can see everybody puts screws differently, and you can actually see that indeed those screws are short and angled laterally to the side. So that's a technique called a cortical screw. It's not a technique that I use. I don't believe cortical trajectory is the right way to do it. But you could see they have less purchase than a normal screw, pedicle screw would have. All right, I'm still working on this upper disc. And you know, Shot, it's not easy to get to it. How's he doing? Shot? Shot? All right, I feel like I'm right at the back there. A lot of bone. Give me an AP. Seem to be wide there. I'm going to have to go in a little bit more medial. Pressure. Let's try again. Shot. Shot. I feel like I'm hitting the facet. AP. Let's take a look. Okay, definitely hitting the facet. I'm placing two needles at the same time. That way I can minimize the radiation for the patient. Yeah, I think I'm a little bit too lateral. I need to go a little bit more medial. There, try that. Shot. Yeah, it's bad stenosis. Shot. You can feel the, not just disc herniation, but the stenosis is really bad.
Your head down. You're doing great.
Give me an AP.
Keep your head down. You're fine. Slow, deep breath.
Yeah, it looks good. All right, lateral. So we're placing multiple needles at the same time. As somebody said, acupuncture. Normally we can get multiple discs with one incision, but you can see that it's not possible with today with this patient, okay? Shot. So I'm placing the bottom needle right now at 4-5. Shot. Can feel the herniation.
You okay? You okay?
Shot.
Gosh, 2 minutes. Head down, all right? Good job. Perfect.
This one is tough. It's so collapsed. This is a very degenerated disc. People ask me all the time, can you do a degenerative disc disease with this procedure? The answer is yes, of course. As a matter of fact, that's what we're doing. Notice the starting point for the higher discs are always more medial. Very important. This will be our last needle. So the needles are important because these are special kind of needles that allow navigation. And navigation is a process where I'm going from one place, which is outside here, where we are, into another location, which is the herniation. And we're navigating through the muscles and around the spine. Shot. So this navigational process is best done with these needles. They're the least invasive. They're able to be directed. Shot. Give me an AP. So they're directional needles because they have a beveled tip, so it allows me to steer them. And I'm steering them through a safe path, starting here outside and ending inside the herniation. Does that make sense? And you can see on that view the beauty of the positioning of the needles. Now also notice the screws and rods. The screws are angled outwards. Again, that's not a typical type of pedicle screw. That's called a cortical screw trajectory. And once again, I don't place cortical screws because I don't believe they work as well. But every surgeon places screws differently in a different way. All right. We try not to put screws at all nowadays, by the way. Now that said, we do have a fusion coming up for those of you that want to watch. A lumbar fusion. Lay still.
Keep your head down, my friend. You're doing great.
Yep, you're doing awesome. Just lay still. We're almost done. I need him awake though, so we're going to need him awake for this part. Now how long has he had this back pain for, Shot? Since June. You're doing great. Lay still.
He's awake.
Yep.
He's feeling it right now.
Perfect. We're in. Shot. Beautiful. All right, so we're in on all 4 points. This is the most important part of the surgery, folks. Gaining access to the herniation through the side and doing it safely and doing it exactly, because it's really only about 2 or 3 millimeters of space. So I have to make sure this needle is perfect. And it's through years of experience of doing this procedure that I'm able to do that. So the first disc we're going to test and the second disc we're going to test, these are the L4-5, L2-3. Remember, his L3-4 is fused, and I didn't do it, somebody else did. But that fusion resulted in adjacent segment disease. Are you comfortable?
How are you, my friend?
How long have you had back pain?
How long have you had it since? 6 months.
No, back pain's been longer than 6 months. Maybe it's been bad for 6 months.
Cleared up
What do
for
we
6
have?
months.
He wouldn't tell me anything prior than 6 months. I asked him.
Oh, okay. All right. Well, let's just say 6 months then. So his back pain got bad 6 months ago, and he also has numbness in both legs, weakness in both legs, and he's got severe stenosis. So he's got discogenic back pain and severe stenosis, and that's what we're treating today. Okay? Are you comfortable?
He said yes.
All right. No pain? No pain. No pain is what he said. All right. How bad is that on a scale of 1 to 10? How high did it go?
I'm sorry, what number?
How high did it go?
7.
7. All right. Is that where you get your back pain?
Yes.
7/10. And by the way, I couldn't even get pressure in there because It literally took the dye, all of it, the volume, the entire volume, with very little pressure. Lay still. And you can see it came out the other side as well. So it went across the disc. You could see, show the audience the huge tear in the back of the disc there at L2-3. Is that better now? Okay, you guys see the x-ray with the arrow?
Yes, we do.
That is a tear. The black is a giant tear. There should be no black there. There should be a wall that blocks the black and keeps it in the center of the disc. But huge tear, that's where the herniation came from at L2-3 on both sides. We're going to go in there and clean the tear with the laser. Are you comfortable? Yeah. No pain? All right. Let me know if it gets bad again and how high it goes, okay? How bad is that on a scale of 1 to 10? 10. All right. So now we know he has a 10 out of 10 at, for back pain at L4-5. Is that where you typically get pain? Yeah. But that's where you get the back pain. All right. Concordant. So he had a 7 out of 10 at 2-3, 10 out of 10 at 4-5. Now we get to put him asleep. And when you wake up, we'll be done with your surgery. I want you to count out loud for me from 1 to 100. All right. Henry, let's show the audience, why does a herniated disc in the back or a degenerated disc, whatever you want to call it, folks, why does it even cause back pain? Go ahead and make our first incision, and we're going to place the dilator in the tube. 7mm incision.
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
Okay, welcome back to our live stream. You're currently watching a Duke laser disc repair surgery. It's only done here in Melbourne, Florida at the Duke Spine Institute. We pioneered this technology. This is a type of endoscopic surgery. The endoscopic surgery is done worldwide, but the Duke laser disc repair, which includes what's called an annular debridement, is done right here at Duke Spine Institute. Why is the annular debridement important? It's the annular debridement that eliminates back pain. That's why we're able to cure back pain from a herniated disc. And the herniated disc is the most common cause of back pain, by far. 85% of people's chronic back pain is from a herniated disc. Now, herniated discs eventually become degenerated discs, right? Over time, they start to collapse, turn dark, lose their water content as they undergo biochemical changes. Those changes are brought on by inflammation. You guys saw the inflammation I was talking about on the video. That inflammation over time will destroy your disc and make it degenerated. So collapse, dark, irregular borders of the end plates, just fragmentation of the disc nucleus, scarring of the annulus from all this inflammation. Those are the degenerative changes. How do we know? We've actually seen them right here endoscopically thousands of times. we've done over 1,600 Duke laser disc repairs now. And there's your tear right there. And in those 1,600 Duke laser disc repairs, we've repaired an average of 2.5 discs per surgery. So that brings us up to, what is that? 2.5 times 1,600? Why do I have so much air bubbles? Any ideas? It's gotten a little better now. Maybe it was just some air trapped in the line. So what is 1,600 times 2.5? That's around, what, 4,000 discs that we have been inside of, degenerated, herniated discs. Think about that. We visualize with the endoscope internally about 4,000 discs. I have at Duke Spine. That's a lot of discs to look at on the inside. And you can see the changes that we're talking about, degenerative changes. Other surgeons can't see inside the disc because they don't do endoscopic surgery. 99.9% of spine surgeons don't know how to do endoscopic spine surgery. They call it endoscopic, but they're actually not inside your disc. They call it endoscopic because they like the way it sounds. And even though they're not really doing endoscopic surgery, they'll still call it endoscopic surgery. That's unfortunately the nonsense we're dealing with today in the spine world, is that spine surgeons are doing not the best surgery for patients, but they'll do what they're comfortable doing or what they get paid well to do, because that's what they get paid well to do. And you have to understand something as a consumer, as a patient. Your surgeon may be choosing your surgery based on what's best for them, not what's best for you. As a matter of fact, that's usually what happens. This surgery is the very best, but it's not performed by many surgeons because they don't know how to perform it. And they don't want to know how to perform it because they've been taught to do fusions or artificial discs, which pay a lot better to them than this surgery would. Okay? But I made a commitment when I went into medicine that I was going to do what's best for my patients. As a doctor, we took this thing called the Hippocratic Oath, and I took it seriously. I come from a family of doctors, and it's always been our philosophy as a family of doctors that do what's best for the patient. And if you do what's best for the patient, you will always do what's right. And it's important to me to do what's right. So, while other surgeons are busy doing fusions and laminectomies which cause fusions, or doing pain management procedures that don't work, at Duke Spine Institute we do what works. That's why our results are the best. And these other doctors unfortunately don't even know how to do this surgery because it takes special training, and a lot of it, which they're not given in their training. You see, the training institutes are so focused on doing fusions because that's what makes the most money for the business, that they are not going to learn in those training institutions how to do less invasive surgery that's better for the patient. That's just the unfortunate truth. But good news, patients are researching their options. They don't want to just have fusion surgery. They want what's best for themselves. So they're actually going out and researching their options, which they need to. That's the best thing they could do. And by researching their options, they're finding this surgery, and they're understanding the value of having this surgery for their lives. In terms of the recovery, very fast, one day. In terms of safety, we've not had any surgery complications. And of course, in terms of effectiveness means getting rid of their symptoms. Go ask your spine surgeon wherever you live how much of your back pain they expect to get rid of with their surgery. And you'll be surprised. Most of them will say, well, we don't do the surgery for back pain. We do it for your legs. Or maybe 50-50, you'll get better. Well, at Duke Spine Institute, we don't do surgery for 50-50, you'll get better. We know you're going to get better, otherwise we wouldn't be recommending the surgery at all. So the question is, are you ready to get rid of your pain? Are you ready to live a pain-free life? If you are, we have the tools here that can help you do that. Back pain comes from specific things. We know what those specific things are. The discs, injured discs are number one. After that, it's the facet joints. After that, it's probably going to end up being the piriformis muscle. We don't know yet. We haven't done the study. But just based on my experience, I can tell you the disc, the facet, and the piriformis muscle is probably the most common causes of back pain that we see. Would it surprise you that we don't see any cases of fibromyalgia? You know why? I've talked about this before. Fibromyalgia is a diagnosis the doctor gives patients when they have no idea what's causing their pain. They call it fibromyalgia. But when you know what causes pain, you can actually make the right diagnosis. And fibromyalgia is not that diagnosis. Back pain comes from, and neck pain comes from, very specific structures. They're joints, mostly joints. In the neck, all of the neck pain comes from joints. It doesn't come from anything but joints. Some people think spinal stenosis causes back pain. It doesn't. Spinal stenosis causes pinched nerves going into your legs. So it causes weakness, numbness. This patient has spinal stenosis, but that's not causing his back pain. What causes his back pain is this tear right here that I'm cleaning right now. So I know his back pain will be gone because his back pain is coming from his disc. And what causes back pain in the disc, as I showed you in the video, it's inflammation going on inside the tear. And that tear is what we're cleaning right now. By cleaning the tear with the laser, we get rid of that inflammation inside the disc. Of course, some people it takes a while to go away completely. Sometimes it takes a few weeks, but it always goes away. And it's just a matter of time before it does. So by doing the debridement, what we're doing now, that gives the disc a chance to start healing and get rid of that inflammation and pain. Any questions from our audience?
No current questions, but we do have two comments. One being from Sharaf on Facebook. And they said, good morning.
Good morning, Sharaf. Thank you.
And,
Thanks for joining.
And the second comment was from Canes25 on YouTube once more. And they said, I'm excited to watch this one. I have a severely degenerated disc, very similar at L4-L5, and I can't get out of the pain and huge tears.
Yeah, great. Well, welcome to our broadcast. This is not an easy one because this patient has had, fusion before, and unfortunately, that fusion has caused adjacent segment disease that's severe. He's blown out the discs above and below. They're severely degenerated. Normally, every other surgeon I know would probably end up just fusing this, but I believe we can get rid of his leg symptoms and his back pain with the laser surgery. I've done it many, many times, hundreds and hundreds of times. I've also done it before with fusion, but it's not necessary to do the fusion. That's why we're not going to do it. This can be done endoscopically instead. All right, you can see the epidural veins right there, and you can see a little bit of fat. And again, we're in the neuroforamen, and this disc is this is all herniation here. It's all scarred up. I'm trying to remove it with the laser. I've tried grabbing it with the grabbers. They don't work very well. They're not really taking the pieces out the way I would hope they would. So I'm having to use the laser quite a bit here to remove this herniation. Laser takes a little more time. Grabbers are a little more efficient, but when you can't grab it out because it's so scarred in, you have to use the laser. By the way, for reference, the laser is 1 millimeter wide. That's the little glass thing at the end is 1 millimeter. That gives you an idea of how big things are. This is a small space we're working in. There's another piece of herniation. Let's try the grabber for a second, just see if I can grab anything out. Just tiny little pieces, if anything. Grabber. Just almost feel like this scope is off. It's not blurry or anything, but it seems like its angle is not 20 degrees. Man. It's more herniation. Again, just little pieces coming out at a time. Now, for those of you wondering, where is the nerve? The nerve root is just at the, like right over there behind that metal. Protected. I think the right side is his worst side, right? We're on the left. Oh, that's just a big herniation right there. He has herniations on both sides, and they're pinching the nerves. That's why we're on both sides today. Look at that herniation, just how it looks, just so many pieces all stuck together, scarred together. Some people say herniations look like crab meat. I would tend to agree. A lot of times they do. What's that? Well, we're not, yeah, it's possible. Good. All right. I agree. All right, let's show our audience, Henry, how the Duke laser disc repair actually works.
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
All right, welcome back. We are still working on the left L4-5 disc, and we're getting close to being done. This is the back of the disc. This is where the action happens, where the herniation is, where the tear is, and I just want to try to pull out any fragments that I can. Now, the tool I'm using is called a pituitary rongeur, standard type of tool used in spine surgery by every neurosurgeon, but the one I'm using is a endoscopic rongeur, so it's built specifically for the endoscope. And it's very narrow, and it fits into this endoscopic channel, which is about 4 millimeters. So it's probably just under, it's around 3.5 millimeters. These are all pieces of herniation coming out. The blue stuff. All right. Got a little bit more, a few more minutes here. Come on, Oscar, pay attention. So we've shown both videos, right?
Correct.
All right.
We do have a comment, two comments. I believe they are seeking for advice and or help.
Uh-huh.
This comes from Lacey on Facebook,
Hi, Lacey.
and they
On Facebook.
and they said, I have a conventional, excuse me, I have a conventional fusion at T4 through 5 with foraminal stenosis on the right, above, and below. Also, a disc bulge at T6 through 7 and 7 through 8. Can this also cause right leg sciatica?
No. Your thoracic disc herniations cannot cause right leg sciatica. That's coming from your back, your lumbar. You need a lumbar MRI. Go ahead and type in my, I'm going to give you the link. If you would like, you can send us your MRI and we'll set up a virtual consultation. The link is dukespine.com, henrydukespine.com.
Or I did. It's all good. MRI.dukespine.com.
No, it's not it.
Oh,
I'm giving you a different link, okay? It's MRI, it's dukespine.com /VC for virtual consultation. dukespine.com /VC for virtual consultation. So it's dukespine.com /VC. Anyway, use that link, upload your MRI, and I'll be happy to go over it with you and tell you what's wrong and what can be done to fix it. Okay? But your thoracic herniations can also be fixed with the laser surgery.
sent the link, and she has replied back. Also, I have thoracic pain with deep breaths. Can you help?
Yes, we can help you. But you're going to have to use the virtual consultation. I need to see your MRI. I need to interview you on Zoom, and I need to do an exam on Zoom. That's the only way I can tell you what's wrong and what needs to be done to fix it. So use that link and set yourself up with a virtual consultation. Doesn't matter where you live. We do it with Zoom. And Zoom is a wonderful way for me to do a conference with you. We do these every week with patients around the world. So if you know somebody who's suffering and they want some advice on how to fix their problem, have them use that link.
She replied back, have sent. Thank you. Look forward to meeting you.
All right, wonderful. And the next comment?
No, no other comments.
All right, very good. Okay. Well, this is taking a long time because this is a very abnormal disc, and there's a lot of herniation here. I don't want to leave anything important behind, so I'm trying to clean out as much as I can. I really feel that this is going to get rid of his back pain. I'm not worried about that. I want to make sure I get the stenosis treated. The stenosis is what's causing the numbness and weakness in his legs. So that's my target right now, is get that stenosis as treated as possible. And this stuff right here is what's causing it. Let's get a grabber. Just about done here. And this is really hard stuff. I feel it. It's calcified. It's thick. It's collagenized and calcified from all the chronic inflammation and scarring that's been going on over the years. That's the bottom of the herniation right there. There's just a little, like a little tip left. How are the laser pedals? We got 2 that work?
Yes, sir.
Just about. What?
Couple more minutes, I'll take 5 minutes.
Yeah, but you know we got 3 more to go. So don't get too excited.
I was trying to get a little extra one here. Hopefully we can finish.
Yeah, we've been at the back of the disc now for 10 minutes. I mean, it's been a while. And what I'm doing is I'm reaching over to the other, trying to reach over as far to the other side as I can. Because this guy has a broad base herniation, and I want to get as much of it out as I can on both sides. So I'm reaching medially. You know, some people have more of a foraminal herniation, in which case you want to clean out the neuroforamen. But some people have more of a paracentral herniation, which, you know, crosses the back of the disc, and those are a lot harder to get to for anybody. And paracentral, lateral recess. It's really very, this is the best way to get to them, you know, this lateral transforaminal. All right, I think that's good. I'm done here. So we're gonna put a little antiseptic in here, betadine, clean it out, scope off, thank you. And we're gonna irrigate. What you're seeing is betadine. It's antibacterial. Not that there's any bacteria. We don't expect there to be bacteria, but sometimes people get infections from surgery. We've never had one with the Duke laser disc repair. As a matter of fact, we haven't had a spinal infection at Duke Spine here since we started operating at our surgery center. And that's really because we use the very best sterilizing equipment, and we use the best sterile technique. We use the best drapes, like this stuff here, Ioband and DuraPrep. And we give antibiotics in the vein, we give it in the wound. So we go through extensive process of preventing infections, and we've never had an infection here. Spine surgery is one of those types of surgery where infections can be, you know, unfortunately quite common, but not when you do it right and you do it minimally invasive. All right, next we're going to move up to the L2-3. You could see above the fusion there, we've got our guide wire in. It's at the front of the disc. I'm going to take this needle out, and I'm going to make an incision in the skin, 7 millimeters. Our patient is asleep. Dr. Berndes is doing a wonderful job of keeping him asleep. And now we're going down to the L2-3. Let's see where we are. That's where we are? All right, good. Yep. Now this is a more degenerated disc than the L4-5. It's more collapsed. Okay? Once again, we didn't do the fusion, but unfortunately, one of the problems with fusion is people get adjacent segment disease, right? So they end up degenerating the disc, damaging the disc during the fusion, or they just never treated all the disc problems during the fusion. A lot of surgeons leave bad discs in the spine so they can come back later and do the surgery at another date. We don't believe in doing that to patients. It's not right. Who wants to have surgery more than once on their spine, right? Any takers for multiple spine surgeries? Nobody wants multiple spine surgeries. So I don't know why surgeons won't do what's right for the patient the first time and fix all the bad discs. That's what we're doing today. I could easily have this patient do one disc on one side and bring them back and do another disc on another side. But the truth is that's just bad medicine. In the right world, in the ideal world, you fix all the problems at one time. That should be good. Okay? And unfortunately, most spine surgeons don't do that. They just fix one thing at a time. So the patient has to have more than one surgery. You're good. Perfect. For what? I'm sorry? No cold welding. It was close. We had a little cold welding concern, but all right, any questions? This is a surgery that you folks that are watching on YouTube or Facebook or Twitter or LinkedIn, you guys can ask us questions. And by asking me questions, you'll get your questions answered. No question is a bad question. This is an educational video and transmission, so we want people to learn from it. All right, much more collapsed disc. You guys see the end plate on the left of L2, the end plate on the right of L3, and a little bit of disc material, and then pretty much a black gap, you know, down there. That's the reason why you're not seeing a lot of disc material here is there isn't. It's degenerated. So this patient had a herniation. It all started with what's called an annular tear and then a herniation. And over the years, because the herniation wasn't fixed with the Duke laser disc repair, look at that herniation there. You guys want to see this? Henry, take a look.
We see it.
You see it?
Yep.
Here, let me see how big it is.
Yes, we do.
So when I put the dilator, it pushed that herniation back into the disc. That's one of the nice things about the inside-out technique, is you actually approach the herniation from the foramen, you hit it with the front of the dilator, and then you shove it back into the disc. And then you can safely remove it from inside the disc. All right. Woo, that's tight. Really tight. There's the back of the tear. And we need to clean that tear up with the laser. Huh? So I was watching a movie last night. Some of you may remember this movie. It was made in 1980s. 1982. It's called Gandhi. How many have seen the movie Gandhi?
I have.
Yeah. Well, it's impressive that you have, Henry, because that's an old movie and most people don't even know about it. And I had my son and I watching it. Is my son there?
He is not. No.
All right. Well, he was watching it as part of his punishment. I'll be honest. Okay, he's a teenager, still learning. And he was fighting with his sister. I'm going to have her watch it next. But for those of you who know who Gandhi is, he is an incredible person. I think he won the Nobel Prize and basically freed India from the imperialistic reign of Great Britain, okay? And he did it with nonviolence. So that's the message for teenagers. Important movie. And we watched, well, 2/3 of it because it's a 3-hour movie. And he learned a lot, watching it. So
Did you see that on Netflix or is it on a
I paid for it on Apple. Yeah. Yeah, I have an Apple TV subscription, and I just ordered it, paid for it, and it needed to be done. And anyway, one of the scenes in the movie, Gandhi is visiting areas of India by train, learning about Indian culture, Indian people, the challenges the Indian people have under British reign. And of course, the British nobles, they owned the land and controlled the land in India. And of course, the Indians provided very cheap labor for them. So in one scene, he's visiting these fields of India where they're growing something called indigo. It's a blue dye. And the British forced the Indians to grow this blue dye for their clothing, their textiles. It's a royal blue color, as you can see. And unfortunately, they did something very ugly. They made the Indians grow this exclusively as a crop and then stopped paying them for it and forced them to sell it at a very low price. And they had to because they were starving. They had no food. Okay? So they forbid the Indians from growing food in their fields, and they could only exclusively grow indigo. And indigo is not edible. So anyway, that was an interesting scene because we use the indigo dye ourselves here in our surgery. And I was telling my son, yes, we get that dye from, I guess maybe it comes from India. I didn't know that. All right, any questions from our audience?
No current questions.
We're pretty much done with this one. I don't see anything else. Maybe a little bit right there. This was a lot quicker because the disc was so gone, basically. Not much to work on. Let me get that little piece. Let me see if I can get that out. We're done with this one. We're going to move to the other side. Anyway. Feel free to ask questions, as I've said. This is a live stream so that people can watch and learn and ask and participate. You're watching endoscopic spine surgery in the United States. This surgery is outpatient. The fusion that I would be doing on him if I didn't do this surgery would be something that would be much more invasive. I would have to take his old screws and rods out to be able to make room for the new screws and rods. And the incision on his back would be a foot long, 12 inches, easily. But instead, we have a 1/4 inch incision. And I actually have 4 of them. You could see those incisions. I'll show them to you. They're small. One of them is right here. You guys see this right here?
Yes, we do.
Now, the incision we would need to do, if I was doing a fusion like he had originally done, I would have to make the incision this long. Okay? You have to open up that big because you got to go below and you got to go above where you're operating to get the exposure. Because you're really cutting the tissues, the muscles and stuff, and you're bowing them out. Well, if you bow them out to be able to see over here where you need to see, you would have to cut up to this high to bow everything out to create enough room to do the surgery if there was an open surgery like a fusion. But this surgery is the only surgery that takes the place of a fusion. Because a fusion fixes back pain if it's done right, and it fixes leg symptoms from stenosis. If you do a decompression and fusion together, you can get rid of leg symptoms from pinched nerves, spinal stenosis, and you can get rid of back pain from the disc or facet. And this is the only surgery that can take the place of a fusion and eliminate the need of a fusion. All right, now we're going to do L4-5 from the opposite side. Sean? That's better. Leave it alone. That's good. Yeah, you can take it out. So now we're on the right side. This is the side where he has more leg symptoms, so worse stenosis. All right, we're making our incision 7 millimeters, 1/4 inch. And now I'm going to head down with the dilator. You guys want to see the dilator? People ask me, well, how does the dilator work? Well, think about muscles as being fibers. There are muscle fibers. We all know that. And when you have fibers, you can use a tapered tip to go through the fibers like that. You guys see that?
Yes, we do.
And then come out. And then the muscle fibers aren't damaged. You haven't damaged the fibers. All you've done is take the space between the fibers and spread it. This is how endoscopic surgery doesn't cause damage. It goes between the fibers of tissue below the skin. Now the skin is a solid membrane. You have to cut it. You can't spread it. But everything below the skin can be spread like fibers. Okay? That's why this surgery is so amazing. It doesn't do any damage to the body at all below the skin. Whereas other spine surgeries destroy your spine. They destroy your spine, they destroy your muscles, they destroy your fascia, they destroy your subcutaneous tissues, they destroy everything. But we did it that way for many years. We still do it that way because people don't know any better. But that's why we try to educate people, because we want you to know better. It's important that you know better so you don't have bad surgery done. Bad surgery is dangerous surgery. Okay? It's dangerous. Why would you want dangerous surgery? Why would you want surgeons who destroy your body with fusions or artificial discs? Normally, we would show you our comparison video. It may be bent.
Oscar, yeah. Another. Let me see. Don't open
Never
it.
mind. Don't open it.
Not yet, Oscar.
It was just bent a little bit because he was squeezing down. Dr. Berndes needs to keep him a little more sedated. No, the L2-3 is very collapsed. That's why. I could blame Dr. Berndes, but the truth is that's a collapsed disc. I think that's good.
If it was general, you could blame me.
If it was general anesthesia, it'd be okay.
I would definitely think.
You're funny. Yeah, it's perfect. All right, you all see the tube? Jordan, show them the tube and the disc at L4-5. That's right. Good, thank you. So we're in the back of the disc at L4-5 where the herniation is, and the tear where the herniation came out is. We're going to remove the herniation and clean the tear so that the body will heal naturally without any metal or implants, and that healing will allow his back to be pain-free. Okay? Look at all that inflammatory tissue. You guys see it? I'm not talking about the red things floating, that's blood clot. But look at the inflammatory tissue. Look how pink it is. Can you guys see that pinkness? That's where all the back pain comes from. That is not normal. That is called granulation tissue or inflammatory tissue. You want to take another snapshot of this one? Oh, hold on. Let me try to clean it up, the picture. It looks, what do you think there? That looks pretty good, right? Henry, can you get a picture of that?
I just was. I was going through the screen.
Take a couple of pictures. And let's give that to Arias again for our paper, all right? But you can actually see, also, there's the herniation. I want to give it to Carl. I need you to send it to Carl as well as last week's. Remember we have some from last week? I need those pictures to go to Arias.
The ones
and
I sent.
Carl.
The ones I sent last week, I sent it to them. But I'll send these ones later today.
All right, you sent it to Carl?
Yeah.
Man, that's a big herniation right there. Holy mackerel. Oh, I can't even get it all. It's breaking up into pieces. Huge herniation. It's just coming out in pieces. It'd be nice if the whole thing came out. I guess we're asking for too much. Anyway, the granulation tissue is a sign of inflammation, ongoing inflammation, and that's where the back pain comes from. Oh yeah, there we go. That's a decent size. Any questions from the audience?
No current questions, but we do have a comment from Sharaf on Facebook.
Uh-huh.
And they said, I sent the MRI January 11th of 2023. The MRI review wants a new one and sent emails, but no response. And I asked Dr. Duke. He said we can use more than 1 year if I still have symptoms. My MRI was done December 27th of 2022.
Yeah, your MRI should be fine. Will you call Sam? You know her extension, Henry? 1299. Will you ask her why Sharaf's MRI review has not been done?
I'll let her know.
Yeah. Yeah, I would like to know from her why it hasn't been done. Because there may be other people like Sharaf that aren't getting their MRI review done. Sharaf, did you get any communication from my office about your MRI review? Did you get, you should have got a confirming email when you submitted it. And then they should have been in touch with you by email asking for something. So, did that happen?
He responded, yes, I did.
A confirming email. But did you, what was the last correspondence from our MRI review? Is Sharaf outside the United States or in the United States?
I do not know.
Well, Sharaf, I'm trying to solve your problem, but also other people's problems. I'd like to know why we dropped the ball, if that's what we did.
Until we reply back, we do have a few other questions.
Sure, I'll take the other questions while we wait for Sharaf.
Oh, he just replied back. He says, I received the images you sent via Dropbox, but the images are too old for us to recommend treatment. We need images that are less than a year old to do a recommended treatment.
And then, did you respond? Did you respond to that email saying, Dr. Duke said it's okay? Or did you have any response at all to that email? Did you respond to that email? And if you didn't, it's okay. All right. Well, give me something to work with here, Henry.
All right, no response just yet, but we do have a question from Sunil on Facebook.
Sunil.
And,
All right.
and they ask, what causes the leg pain after the endoscopic laser disc repair?
What causes leg pain after endoscopic laser disc repair? Well, if you had the Duke laser disc repair, there's several possibilities. One is piriformis syndrome. Piriformis is a torn muscle in the buttock that the sciatic nerve can go through. The other is the nerve could still be healing just because we've taken the pressure off the nerve. The nerves now have to heal, and sometimes they take a few weeks or a few months to fully heal. Those are the most common. Another possibility is a recurrent disc herniation. If the patient has lifted something or bent over or done some type of bending at the waist, they could re-herniate and cause a leg pain from a re-herniation. So there's a few different things. If it's true sciatic pain, it goes from the back all the way down to the foot, and that would definitely be a nerve issue. But if it's pain from the back into the knee and thigh, it could be a facet joint problem. So there's a lot of different possibilities, but I've never found it ever to be from the nerve that we've operated on. So the most important thing is to get seen and diagnosed. All right, what other questions do we have?
We have another question from, or a comment from SARS Logistics on YouTube. And they said, I'm still suffering from my neck fusion C5 through 6 and spacers, headache in cold weather, and clicking my My doctor says keeps telling me that it's gas from joints.
It's not gas in the joints. The clicking is your facet joints. Facet joint arthritis. That's what's causing your clicking. So you have a problem with your facet joints, and it's not gas in the joints that causes the clicking. There's the herniation, by the way, at right 4-5. This is the herniation that's moved north under the nerve roots. We're just outside the disc in the foramen. So what you need done is you're going to need a consultation, and give that person our consultation, virtual consultation. The dukespine.com//VC, virtual consultation. dukespine.com/VC, and submit your MRI. We'll take a look at it, and we'll give you a diagnosis as to what's going on. But to me, it sounds like facet joint pain. Facet joints make the popping and clicking, and they also can cause discomfort, and they also can get quote-unquote gas in them, as well as the disc can have gas. That gas is called vacuum space phenomenon. It's not really gas, it's an absence of material called a vacuum. If you actually poke a needle into that, you're going to hear a hissing sound because it sucks air in. We've heard it before. Very common. All right. This is the herniation again under the nerve root, right there. And it's traveling north. So I'm going under the root right now. And zapping the herniation out from underneath his nerve root. The nerve root is buried in that fat and veins. By the way, you see the redness? That's inflammation. That takes time to go away. So people that say, oh, I still have some leg symptoms like pain, come back, that's the nerve healing from all that inflammation. The surgery gets rid of the source of inflammation, but it doesn't get rid of the inflammation. Inflammation can actually take time to go away. And during that time that it's going away, usually weeks, that patients can actually have some discomfort. Yeah.
We have another comment.
Sure.
This comes from Dudley on YouTube.
Hello, Dudley.
And they said, Dr. Duke is a great doctor. He actually does the exam on you right. He checks everywhere. You're hurting unlike other doctors. Or you're not hurting unlike other doctors. And he is for the people, not being sold out to hardware companies. Thank you, doctor.
You're welcome. I believe in doing the right thing for people. By the way, the nerve is right up there. You guys see that? That area right there? And this herniation is underneath it. And I'm trying to get as much of it out as I can, because this guy had a herniation right here that didn't just go backwards. See, this is the back of the disc. It didn't just go backwards, but it went back and up. And so I'm trying to work very carefully underneath the nerve and not damage the nerve at all. But try to get out as much of this herniation wedged up underneath the nerve right there. You guys see that? And there's the bone right there. So I'm trying to work between the nerve and the bone and get this blue stuff out. But just have to do it very carefully. Yeah. Thank you for the comment. I appreciate that. Yes. You cannot make the right diagnosis on a patient with back pain or leg symptoms without doing a good, careful physical exam. So people all the time ask me, hey, why do I have leg pain or why do I have back pain? I don't know until I actually see your MRI and examine you. Yeah, see the nerve right there, guys? That's pretty cool, huh? The side of the nerve, that white thing. And then just below it, you got the veins and stuff. All right, let's see the grabber again. So I feel pretty good. We're almost done here. I just want to make sure I'm not leaving any herniation underneath the nerve. What's cool is you could see the side of the nerve there. All right, and then you could see like a little space underneath it, and then you get the veins and ligaments of the epidural area just underneath, behind the disc. Again, I'm just trying to get as much herniation out as I can. You know, surgeons never get all the herniation out. I don't know if people know that. It's not possible. The only way you can even come close is endoscopic surgery, because you can actually see what's left. But with other surgery like discectomy that people get, you can't see inside the disc. You have no idea how much herniation you're getting out as a surgeon. You have no idea. You're just grabbing blindly inside with a grabber, with the pituitary, hoping you're getting everything. But here you can actually see. It's incredible. You know, it's sad that more spine surgeons don't do this. It's so amazing. I mean, same thing in orthopedics, right? Orthopedics used to be just no endoscopic, just go in there and kind of grab around in the joints. And then when endoscopic came, everyone learned it. Everyone started doing it because you can actually see what you're doing. Well, this is the same. Endoscopic spine surgery is the same. It's going to be the future of spine surgery. The problem is training all the doctors and getting them away from fusions, because you're not going to need fusion or metal when you do this kind of surgery. And the companies that control the metal, they know that, and they're keeping this technology away from the doctors as they train. They don't want them seeing this technology. We have a broken system in America and the world. because these same companies control the technology around the world. All right, once again, there's the side of the nerve right there, right where the laser is, and just below it are veins and ligaments, and I'm trying to stay just right here in the safe area below the nerve, removing as much herniation. I got about 1 minute left here. I'm going to go laterally as well, get the lateral herniation. I should be done in just a few minutes with this disc, and then we're going to move on to our last disc, which is going to be the right L2-3. Any questions?
Yes, we have a question from Lacey on Facebook,
All right.
and they asked, "Oh, when the disc material is removed, what keeps the space from collapse and future pain from nerve root pressure?"
First of all, collapsed discs don't cause nerve root pressure. That's a misinformation or misbelief, whatever you want to call it. Collapsed discs do not cause nerve root pressure. What causes nerve root pressure is when you have a pinched nerve, and a collapsed disc doesn't cause a pinched nerve. I don't know who told you that, but that's not true. What causes a pinched nerve is either going to be a herniated disc, which is 95% of the time, or a cyst, or a hypertrophied facet joint, or a combination of those. So collapsed discs never cause nerve pressure, okay? Second of all, we're not removing the disc with this surgery. We're removing the herniation. The herniation is already gone. It's already out of the disc. It's not like we're taking the disc out here. We're taking the herniation out. So that's one of the biggest problems. Discectomy, they take the disc out. That's why it's called a discectomy. We're doing what's called a herniectomy, okay? We're taking the herniation out. Herniation is already out of the disc. It's out of place. It's somewhere where it's not supposed to be. And I'm just removing it from that somewhere. Does that make sense? This is all you need, folks. You don't need metal, you don't need spacers, you don't need artificial discs. This does it all. Whenever you have a degenerated disc, herniated disc, ruptured disc, protruded disc, extruded disc, migrated disc, prolapsed disc, this is it. This is the surgery that fixes all those conditions, okay, and stenosis. You don't need anything more than this. This is my go-to procedure for all spine problems. It works for 99% of degenerative spine issues. The occasional patient it won't work in has severe deformity or bony stenosis that can't be fixed with this type of surgery. But it's rare.
Put a little skin num-num on the last one.
Yep. You have some skim on them? Great questions.
We have another question.
Do we use the same concentration in the discogram guide as we always do? Same, yeah. I just checked.
Yes, I'll take the question.
This comes from Danielle on YouTube,
Hello, Danielle on YouTube. Welcome to our live stream.
and they asked, "Does this thread do photos? I have photos of my current MRI results."
Yeah, we don't just do photos and MRI checks. Folks, just so you know, we offer a MRI virtual consultation, but we don't do it by patching in photos and reports. It's a formal process. It requires you fill out a brief history and you upload your images, and not just one or two, all of them. For a surgeon to be able to see what's going on causing your problem, they need to see all the pictures, not just one or two. All right? There's literally 100, usually over 100 pictures that we look at. And we have to look at them on a special software called the PAC system that takes your DICOM formatted images and presents them to us in a way that we can actually see it and scale and be able to do measurements and be able to do side-by-side, axial and sagittal. So everybody thinks just throw up a few pictures and a report and we're good to go. No, we're not. That's the difference between a doctor who can actually fix your problem and somebody who's just guessing. We don't go based on the MRI report from the radiologist. Radiologists are not surgeons. They have no clue what surgery needs to be done for. So they read out what they feel like reading out, and they leave out a lot of details that we surgeons look at that are important to us, which is why most people, when they go to a good spine surgeon, the spine surgeon always looks at the actual MRI. They don't just take your report. And a good surgeon always does a physical exam. They're going to mash on your back, figure out where your pain's coming from. They're going to check out your nerves. They're going to do a lot of stuff to make sure that the surgery they're recommending for you is the right surgery. It's easy to recommend the wrong surgery. Most surgeons recommend the wrong surgery. But we don't want to recommend the wrong surgery at Duke Spine. We want the right surgery. This right surgery is the surgery that gets rid of your symptoms, okay? And that gets rid of your back pain, gets rid of your leg pain, gets rid of the weakness, numbness, and tingling in your legs, if it's something we can get rid of. Okay, so that requires a thorough investigation, special questions and answers. So when you ask about just uploading images, that we don't do that. You have to do a consultation. There's a formal way of doing it, and our consultation, by the way, is one of the only virtual consultations where you're going to get a diagnosis, a treatment plan, and get all your questions answered. Okay? And we've been doing it now for a couple of years, and it works really well. But we've got it streamlined to where we're only asking you for the information we need. We're only, the process is very efficient. So for people that want to shorten it and make it even less than what we've made it, you're cutting corners we're not willing to cut. So I'm not comfortable making a diagnosis and recommending a treatment plan for that diagnosis just based on a few pictures. I need history, I need the MRI images, all of them, and I need them viewable on my PAC system. So JPEGs don't work. We need DICOM. And I need to do a physical exam with you on a Zoom call. Can you pull back the shot? That's good. That should be good. All right, that's good. So we are perfectly capable at Duke Spine of providing you a diagnosis about 98% of the time virtually on Zoom with your full MRI images, your history, and me doing a physical exam with you. Okay? And that's the best you're ever going to get in today. There's no other spine surgeons I know of that will do a Zoom diagnosis and treatment recommendation. I think maybe there's a couple worldwide, but nobody's going to do it as well as we do it, and we do it quite a bit. So Duke Spine Institute is a pioneer and leader in the world in virtual medicine for spine care. Okay? Anybody can do virtual visits, but to make the right diagnosis, that's hard to do virtually because it requires doing a physical exam. Well, I guess my irrigation's okay. And believe it or not, I actually have you, the patient, help me with the physical exam. There's things that I can see on Zoom, and there's things that I need your help. For example, I will have my patients mash on their back or buttocks to figure out where that pain's coming from, okay? Now, sometimes, and this is the trick, sometimes people have a diagnosis like piriformis syndrome, and it's not acting up when I do my virtual consultation. And so therefore it's going to be invisible to me. There's no possible way I can diagnose a piriformis without there being tenderness in the buttock at the time of the exam. And that's, unfortunately, it's not a limitation of the virtual consultation, but it's a limitation of all consultations. To diagnose the source of back pain or neck pain accurately, a patient has to have that pain when they go see you as a doctor. And the doctor has to actually do the exam. Most doctors don't even examine patients anymore. It's shocking. They don't touch the patient. They just look at the MRI report or MRI, and they say you need a fusion or you need an artificial disc. They don't do a thorough exam. A thorough exam, look, let's face it, the exam is kind of for us, it takes a lot of time, and you know, you don't really get paid. So a lot of doctors cut corners and they don't do the exam. Okay, but I'm going to tell you this. I used to believe in my naivety that an exam wasn't important, right? And that's because when I was starting out in neurosurgery, you know, everyone tells you the exam's important if you have a good teacher. But then you're like, yeah, whatever, it's a brain tumor, right? You got to go in and take it out, no matter what the exam shows. And that's true, right? The exam's not that important in making a treatment recommendation. But for the spine, it's a completely different. Look at that herniation. Henry, you want to see this thing?
Lights on, please.
Yep.
Turn off the irrigation. Oh, yeah. Can you see this thing?
Yes, we do.
Is it clear? Clear view?
Yes, yes.
Pretty cool, huh? All right. Anyway, with spine, it's important to do. All right. So let's say you've got, you know, if you've got fibroid, uterus fibroids, right? How do you diagnose that? You diagnose it with, I think, ultrasound. I'm not really sure. I'm not an OB-GYN. But you diagnose it with, say, a test, right? And then the patient says, I'm having bleeding, a lot of bleeding. And you as a doctor go, okay, we got a fibroid, we got a lot of bleeding. Surgery, right? You don't need to do a physical exam to figure out that the patient needs treatment and what the treatment is. So a lot of medical diagnoses don't require a detailed physical exam. But I'm going to tell you this. For determining the source of back pain or leg pain, a detailed physical exam is essential. You cannot do it without a detailed physical exam. So all these surgeons are recommending surgery without doing a detailed physical exam, and patients are getting the surgeries, fusions, laminectomies, whatever. And they're not doing well. The patients are not getting great results. And the reason they're not getting great results is because they didn't have a physical exam properly done to make the right diagnosis. Okay, ultimately, it's not the physical exam that's important. It's making the right diagnosis that's important. So, but you got, oh, there's a piece of herniation. But you've got to do the physical exam to make the right diagnosis. All right? And folks, I'm going to tell you this, very important. The MRI report does not ever tell you where the back pain comes from. Okay? Unless you have a tumor, all right, which is rare. If you have a tumor or an infection in your spine, that is, the MRI will tell you. And there you go. You don't really need a physical exam because the MRI tells you there's an infection. And the treatment is going to be surgery to clean it out and antibiotics through your veins for months. Okay? So the point I'm trying to make is the importance of a physical exam in the diagnosis of chronic back pain. It is indispensable. It's not possible to make the right diagnosis without it. Every single patient I have ever operated on, you know, in my spine career in the last 20 years at Duke Spine, I have always done my own physical, or I've had a doctor that I trust to do the physical. But even then, even if I have Dr. Damola, Dr. Patel come in and do a physical, I always check myself. Why? Because it's too important. After all, the patient's there for a reason. They want relief of those symptoms, and it's my job to figure out what's causing it. Now, if they have a piriformis and they don't have it at the time that I see them, or it's mild, or their disc problem is overshadowing other sources of pain, well, once I fix their disc problem, maybe the other sources of pain start becoming more loud. Okay? That's a very common phenomenon. And that's why when people say, oh, I'm having some leg pain or some sciatic or whatever, back pain after surgery, I always want to actually examine them, see where is it coming from, okay? Where is it coming from? And what I can tell you in all my years of doing this, it never, ever comes from the disc that I fixed. I've never seen it come from the disc that I fixed with the laser, okay, unless they reherniate, in which case it will. The reherniation rate with this surgery is 1%. 1 in 100 will reherniate. Okay, we haven't had any reherniations lately because our patients have been really good about following instructions, you know, with the bending and the lifting at the waist, bending and lifting. And those instructions are 25-pound maximum lifting for 6 weeks after surgery, then 40 pounds maximum for the first year, okay? No more than 40 pounds. And if you follow those instructions along with no bending and no contact sports, no bending for 3 months, you're not going to reherniate, okay? Or the chance of reherniation is extremely low. Let me just put it that way, because I have had somebody reherniate even though they said they followed the instructions. And that was a cervical, neck. And they woke up in the morning and they had neck pain and arm pain. And that was like, I don't know, 2 months after their surgery. But they weren't sleeping with a neck brace, okay? And they're not supposed to 2 months after surgery. It's usually the first 6 weeks. So they did everything right and they reherniated. So reherniation, it can't prevent all of it, but we can minimize the risk of reherniation by having restrictions after surgery. And that's what we do. But to make a diagnosis, I need to do a physical exam. And most of the time I can do that virtually, which is why we offer the virtual consultation. All right, we're just about done, doctor. Like 2 minutes. Any questions from the audience?
Yes, we have a question once more from Danielle. Before I say her question, she did commented that she is dealing with this lower back pain for too long. I'm 36 and want to be able to run again. Lately, I cry every day with no hope. So thank you so much for answering my question. You have given me some hope. It actually makes me feel better. The question is an L4 through 5 disc, or is a L4 through 5 disc disease where my disc is bone on bone permanent? And is the hypertrophic and SCL rose facet joint pain something you have treated on video? I never had anything but for injections.
Yeah, all right, great question. I understand your question. So first of all, any back pain people have, I mean 99.9% of patients, we can cure your back pain, okay? I'm not saying we can cure with one procedure. Like, there's not one surgery necessarily that's going to cure it. But we can cure it, and what it may take is a couple of different procedures. For example, this laser surgery will definitely cure the back pain from the disc that's damaged. So if you have a damaged disc, like a herniated disc, degenerated disc, bulging disc, that's causing back pain, this surgery will fix it. And it doesn't matter how many you have, we can do it on every single disc that needs to be done. It's my job to figure out if the disc is the cause of your pain. I do that by using the physical exam, seeing where your pain's located, and looking at the quality of the pain. Is it worse with rotation, extension? That leans more towards facet. Are the facet joints tender on exam? That leads more towards facet. People with discogenic pain, pain from a damaged disc like this patient, they don't have facet tenderness. Okay? They don't have tenderness of the disc on exam. You can't mash on the disc with your fingers, 30 seconds, because the disc is too deep. It's too far inside. And being so far inside, you're not going to press on it. You're not going to elicit a tenderness. But the facet joints do get tender. So yes, we can fix your pain. I have no doubt about it. I just need to know where it's coming from. And that requires an MRI review and a physical exam. Okay? Let me just look here. Hey, laser here, laser here. One last piece of herniation just underneath the nerve root in the foramen. And then as far as facets go, yes, we treat facet joint pain as well. We actually have developed a new technology. It's called the Duke plasma rhizotomy. We're actually doing one today. And we've been able to get rid of the facet pain successfully in every patient we've done it on. Okay? So it works. It's better than a radio frequency ablation. A radio frequency ablation, unfortunately, is very weak and cannot adequately target the pain nerve. It's just guesswork. And a lot of times inflammation of the facet joint, like arthritic inflammation like you have, blocks the needle that the doctor uses in the RFA. It blocks it from working because there's so much scar tissue and bone spurs around the facet joint that they can't get the needle in the right spot. But we've developed a new technology that allows us to destroy the pain nerve to the facet joint no matter how arthritic it is. And so far we've been doing it 8 months, and I did it before 8 months as well as part of my open surgeries, but it's by itself for the last 8 months, and it works amazingly well. So we can treat facet pain and we can treat disc pain. And that's right there is about 98% of all chronic back pain. If you have a sacroiliac joint pain, we can fix that as well. We did our very first sacroiliac joint plasma rhizotomy last week. The patient had no more SI joint pain afterwards. It was gone. It's an outpatient procedure. It took us 30 minutes to do it. Patient went home 30 minutes later. So whether you're having facet problems or you're having disc problems, Duke Spine can fix them. And it just requires making the right diagnosis, which requires a physical and your MRI. All right, so we've completed the surgery. We had to do 4 1/4-inch incisions. They're all Band-Aid incisions. And we did that because the discs were so far apart from each other, I had to do separate incisions. I feel good about this. I think his leg symptoms are going to be much better. He's got numbness in his legs too. The numbness takes about 6 months to a year to go away for the nerves to completely heal. We can't speed that up. All we can do is get them unpinched, which I feel we've done today. The rest is up to him to heal. Everybody heals differently. That's why some people take a few weeks for their nerve pain to go away afterwards, but that's just normal healing. All right, if you got questions, type them up. I'll be happy to answer them for you. I'm going to come see you guys in a few minutes and answer them directly, but type your questions up. Don't forget about the Duke Spine Institute app. It's in the App Store. It's free, and I think it's very useful. Let's go ahead and run a video testimonial. All right, I'm here with one of my patients who traveled from Australia to Florida to the Duke Spine Institute for treatment. And you look happy today.
Yeah.
Yeah? Why are you so happy?
I'm happy because my back pain is gone.
Your back pain is gone.
And my leg pain is gone
Awesome.
from the disc here.
From the surgery yesterday.
Surgery yesterday, yeah.
And you had the Duke laser disc repair.
I had the Duke laser disc repair, yeah, that's right, yeah.
So why did you come all the way to Florida from Australia for the Duke laser disc repair?
I've been suffering from back pain and leg pain for nearly a year after an accident. So I did a lot of conservative treatment like physiotherapy, exercise physiology, but it hasn't cured my pain. The pain was chronic, and I've been suffering from a lot of issues, emotional frustrations and things, and sleepless nights. But a couple of neurosurgeons back in Australia has offered me a surgery. They both offered me a fusion, which I don't want to go for. So then I have looked into Dr. Duke. I found Dr. Duke, and he's doing an amazing job doing a laser technology and also doing very minimally invasive procedure. So I thought this is what I wanted, and it's a faster recovery. I could go back and work back within a couple of weeks. So that's why I traveled all the way from Australia to US.
Yeah, and we did your surgery just yesterday evening.
Yeah.
So it's around 12 hours now from the surgery, and your pain is gone. And you can see in the video here where we did the laser surgery, we got into your disc endoscopically, and we used the laser to clean the tear in the back of the disc at L5-S1 where their pain was coming from all the inflammation. And now that back pain is gone. And you didn't have to have fusion. You didn't have to go to the hospital. You didn't have to deal with narcotics, right? You said you took a a couple of anti-inflammatories and a muscle relaxer yesterday.
Yeah, but I didn't have much pain about with the surgery because it's laparoscopic and minimally invasive, I believe.
Yeah, that's correct. That's correct. So there's not a lot of trauma, there's no scar tissue, there's just a little incision. And of course, we don't remove any bone or ligaments from the spine. It's all done minimally invasive and naturally. So it's a natural healing of the disc. Now, you said just a minute ago you were suffering with a lot of pain and the effects of pain on your psychological well-being. And I know what you do. You're a nurse who helps patients that have behavioral issues, like anxiety, depression, and maybe other things. But you can appreciate how devastating chronic pain can be on people and the loved ones around them.
That's true. Yeah, I completely agree. It not only disturbs you, also your family. That's what I understood. So psychologically, after a few months, I should say, you will have that frustration of chronic pain, and then your behavior start changing towards others as well. And it's not really, about you. It's also about your people living around you. That's very important. Yeah.
You came here for a purpose. You got your surgery that you had hoped to do. Now you're going to go back to Australia.
Yeah.
You got a long trip ahead of you coming up. And how do you feel about your experience here at Duke Spine overall?
Oh, it's really good. Staff is really welcoming, and it's spot on, and they receive you with a smile, and which is really great. And my father was telling, it's amazing how he never thought that in American health system people the clinicians are like this. So he was treated differently probably before while he lived in US, but it was really amazing, and your staff is really cool.
Thank you.
Say, they're welcoming. They're good.
Thank you very much.
And you are the best. I
appreciate it. It's an honor to take care of you, and it makes me feel so satisfied to see you happy and out of that pain. So congratulations.
Thank you, doctor.
You're welcome.
Yeah. If you're suffering from back pain, this is a very good cutting edge technology and very advanced surgery, which Dr. Duke has developed his own, and without minimal, no damage to the bone, no damage to other things, and easily approaching to the disc and removing it. He is very skillful in reaching there without manipulating any of your muscles or anything, and you can see from me that I have recovered within few hours after the surgery. So I would say if you don't want a long-term complications from the surgery, this is the best surgery you can get done by Dr. Duke here.
Congratulations once again.
Thank you, doctor.
Okay, Dr. Duke Majan, and welcome to our live stream. We're wrapping up a surgery. We just finished what's called the Duke laser disc repair. It's endoscopic spine surgery. The future of spine surgery is endoscopic spine surgery. And why do I say that? Because spine surgery is almost completely done for what are called degenerative conditions. Degenerative conditions are disc herniations, facet pain, even instability and deformity are all degenerative conditions, okay? So about 95% of spine surgery in the United States today is for degenerative conditions. The other 5% is for tumors and fractures and infections. So we're not talking about tumors, fractures, or infections right now. We're just talking about degenerative spine conditions, which is what virtually everybody out there has, is a degenerative spine condition. And the most popular surgery, the most commonly performed surgeries are laminectomy, discectomy, fusions, and artificial discs are on the rise in the last 10 years. These surgeries are all highly invasive and destructive. They're either invasive and destructive, and they don't often address the source of the pain, which is why patients continue to have pain. So there's flaws with these surgeries, big flaws. And they're being done all over the place, all over the United States and the rest of the world. Why? Because that's all surgeons know how to do. When surgeons actually learn about endoscopic surgery, particularly the Duke laser disc repair, what we just did, they're going to realize they can cure back pain, they can cure leg symptoms, stenosis, all cured with the endoscope and a laser, just like we did today. This surgery you watch today is what will be done all over the world, fast forward 30 years from now, 50 years from now. So the sad thing is that it's going to take 30 to 50 years, which means many of you won't benefit from this technology because it's going to be adapted or adopted too slowly. So you got to ask yourself why. And a lot of people ask me why. And the reason is simple. This metal that goes into people's spines makes people rich. And as long as the rich and powerful continue to make tons of money putting metal in, you patients are going to be the victims of unnecessary surgery until you learn to stand up for yourselves and demand less invasive surgery, which is one of the reasons why we do this broadcast, to make you aware of the fact there is less invasive surgery. Fusion surgeons that don't know how to do endoscopic surgery are not going to tell you that there's endoscopic surgery available. They're going to keep it from you. Why? Because they don't want to lose the business. Let's face it, every doctor's office, every spine surgeon is a business. Even we're a business at Duke Spine Institute. We're no different. So businesses need revenue. They need money coming in order to pay bills, in order to pay the overhead, okay? And there's 1 million doctors in the United States, 1 million doctors. And of those million doctors, there are about 8,000 spine surgeons now. There are a mixture of orthopedic surgeons, neurosurgeons, and of course, people who shouldn't be doing spine surgery but are doing it anyway, illegally and immorally, like anesthesiologists or pain management doctors. Point is, there is about, let's just round it up to 10,000 spine surgeons in the United States. Those 10,000 spine surgeons, plus the pain management doctors that do needle procedures, epidural, spinal cord stimulators, those pain management doctors are starting to do spine surgery. They shouldn't be, but they're starting to because nobody is stopping them. And you may actually go to a pain management doctor who recommends surgery for you. You wouldn't know any different because you think that the doctor's recommending something that they should be doing, but they're not. That's why we have this broadcast, folks, to teach you the truth. So between the legitimate spine surgeons, which there's about 6,000, and the illegitimate spine surgeons, which there's about 50 or 100,000, you people that have degenerative spine conditions are getting the wrong treatments, okay? So basically, 99.9% of the doctors you see are going to give you the wrong treatment. Now, some of you are going to say, but Dr. Duke, I had a fusion done and I did great for 2 years. Well, that's right. You did great for 2 years because A, you were lucky you didn't have a complication, because with cervical fusion, the complications rate is now established at 48%, 50%. Let's just make it easy to remember. Half of the patients with an ACDF, anterior cervical decompression and fusion, have a complication. Okay? Do you want to be one of them? I don't. So, fusion complications, metal complications, complications from these other types of surgery are very high, very serious, and it's the patient who pays. Let me ask you a simple question. Let's say you have a complication getting a fusion. Does the surgeon still get paid? Yes. Does the hospital still get paid? Yes. Do they get paid more to manage your complication? Yes. Think about that. The system is rigged to put metal in you. The system is rigged for you to have complications because they're rewarded with higher pay for your complications. Is that a system you want for yourself or somebody you love? It's not for me. Hell no. If you say yes, you're stupid, and just turn this channel off. Go away. Because I don't like stupid people. I don't really have any patience or time for stupidity. I should be patient, but look, The difference is there's people that don't know, and I'm teaching you, and there's people that are stubborn and don't want to believe the truth. Those are the people I have no interest in helping. Okay? Let them weed themselves out, Mendelian genetic, through process of evolution. Maybe their genes will disappear and do us all a favor. We need smart people, people that are intelligent, that are caring, that want the best for themselves. Those are the people that are going to make a change in the world. Okay? And I'll help you. The point is, you may be fine from your cervical fusion. Maybe you're the lucky 50% that didn't have a complication. But that fusion is going to cause adjacent segment disease. What does that mean? It means when we do a fusion or any kind of metal, even an artificial disc, the same problem. They just came out with a study this year, or actually in 2022, that showed patients with artificial disc get adjacent segment disease. What that means is when you fuse this disc, these two bones together, you're going to wear out the disc above and below. It's called adjacent segment disease. The patient we just operated on has adjacent segment disease. That's why he's back here. That's why you saw a fusion. Okay? And we are operating above and we're operating below the fusion. But the surgery he chose this time, not a fusion, but the Duke laser disc repair. We're not damaging the spine in any way to create more business down the road. We're actually fixing it by going through an opening on the side of the spine that doesn't involve removing any bone or ligament or fusing, and fixing the herniations that way. That's what you saw today. You saw the most advanced spine surgery in the world for degenerative spine conditions, and we're trying to help you understand that so you avoid the catastrophes that occur with regular, traditional open spine surgery. Folks, I'm going to tell you this right now. I cannot change the spine world in the United States or the rest of the world by myself. It's impossible. We need your support and your help. I'm not asking you for money. I'm asking you to raise awareness, to share the information you have, to make other people aware of the other options available. Okay? All right, we'll take our first question.
All right. First question comes from Lacey on Facebook, and they asked difference between RF nerve ablation and rhizotomy for facet pain.
Great question. So,
oh, and she added, I am getting a medial branch block today at T4 through 5.
Great, Lacey. Great question. So here's the deal. I can't show you too much just yet, but I want you to understand. Your pain, and that will be determined today with the medial branch block. Your doctor is saying or believing your pain is coming from this little guy right here. That's called the facet joint, F-A-C-E-T joint. Now, the facet joints get arthritis. Lots of people have it. Sometimes it causes bad pain. When a facet joint causes bad pain, you have two choices to fix it. One, do a fusion, which stops the facet movement and gets rid of the pain. But that's a fusion, it's a major surgery. The other option is to come in and find the little nerve that actually goes to the joint. It's called the pain nerve. We call it the medial branch of the dorsal ramus. And get a needle right there and try to burn the nerve, like literally burn it. That's what they do. The procedure is called an RFA, or radiofrequency ablation. The RFA is a rhizotomy. Rhizotomy means to cut a nerve. So they're trying to cut a nerve with a needle. But the problem is the needle is super skinny and very inaccurate. So at Duke Spine Institute, we've developed a new technique. Rather than a skinny little needle tip trying to put it where the nerve is, we put in a big tip, and we're able to burn the nerve quite effectively. We're the only place in the world that does it. It's called the Duke plasma rhizotomy. The advantage is it works better and it lasts. Excuse me. Hello? Yes? All right, be right there. So the Duke plasma rhizotomy is done here at Duke Spine Institute. You have to come to Florida to get it. It's not offered anywhere else. Everyone else is doing, I'm going to say it, the crappy RFA, okay? Because here's the problem. And by the way, we do the crappy RFA too. Dr. Patel, my partner, is one of the best in the world doing it. When the best in the world, Dr. Patel, who works here, does RFAs, his patients still come back all the time because it wears off or it doesn't work that well. It lasts a week, 2 weeks, 2 months, 6 months. The best I've ever seen is a few years, okay? And that's rare. So the average, they tell you, is 6 months. Every 6 months, come back in, we'll do it again. Why would you ever want to do that? So I started thinking, can't we do this better? So that people don't have to keep coming back every 2 weeks, 6 months, whatever? And the answer is yes, we can. And we figured it out. So if you want a permanent RFA that works, you come to Duke Spine Institute. Okay? But it's not an RFA. We call it a Duke plasma rhizotomy.
And we have one from Bianca on YouTube, who I don't believe it's a question, but is seeking for help or advice. They said, I had a MRI, findings in the C5 through 6 herniated disc, and chipped cartilage pressing on nerve, right arm, tingling thumb, no sensation.
Hi Bianca, you have a herniated disc with a pinched nerve. We can fix that with the laser surgery. I recommend you head to our YouTube channel, and I'll have Henry post one of those testimonial links right now for one of our latest Duke laser disc repair cervical. Go to the YouTube channel, go to the playlist, and just scroll down on the first playlist section until you find Duke laser disc repair cervical. And then you can watch a testimonial. And in our testimonials, Henry's done a great job of incorporating actual live surgery footage of the surgery, so you can actually see how it works. The other option is to go and watch one of our live stream, because we live stream all of our surgeries every week except for the plasma rhizotomies, which we're going to start doing, by the way, in February. But you can actually watch an entire Duke laser disc repair endoscopic surgery to fix a herniated disc with a pinched nerve. We do them all the time. It's done with a tiny little 4mm incision, literally a few millimeters. That's it. And there's no metal, no fusion. The disc is kept there, and it's wonderful because your pain goes away, your arm symptoms will go away, but you won't have open surgery. You won't have any swallowing problems. You won't have voice changes like you get with a fusion. Next question.
And that is it.
All right, well, hope you enjoyed the surgery. We have 5 more to go today. That was our first one. And I can tell you the first patient's already in the recovery room, and he'll be going home in about 30 minutes. The second surgery is a plasma rhizotomy. We are not broadcasting it. And the third patient will be another Duke laser disc repair, which we will broadcast. That will be in about 45 minutes to an hour from now. So go grab yourself a diet soda, some popcorn or a hot pretzel, some nachos, come back to the theater, and we'll be here educating and entertaining you